We are here to discuss the topical use of the tranexamic acid, whether it is worthwhile to be an added drug and modality, to be added as a modality, a new modality in the management of the upper GI bleeding or not. This case was admitted to the ICU in Ain Shams University Hospitals. She's a 71 years old female. She was admitted to the ICU with an attack of hematemesis and melena. It's a bit of a complicated case because she has multiple comorbidities. She has a history of being a diabetic, hypertensive, and she's dementia with bedridden due to a previous attack of stroke that left some weaknesses in the lower limbs. On examination of the patient, she has chest infection and bed sores in the buttocks and an obvious bilateral lower limb edema. That duplex was done once she was admitted to the ICU that revealed an extensive case of DVT. So the dilemma was the patient needs anticoagulation and she has a case of hematemesis and melena. What to do? And actually, it's a common case now we see in the ICU. Of course, initial resuscitation was done with fluids and blood. And in order to stop the hematemesis, actually I used the topical use of the tranexamic acid. I put around 1.5 gram of the tranexamic in a 500 ml of saline to help in the wash of the blood. The bleeding actually decreased significantly, and the patient was able to perform an urgent upper GI endoscopy for further management. Here I am saying that it can be used as additive, but not as a sole agent to control the bleeding. Just to decrease it sufficiently to be used out to put the patient for a definite management in the upper GI. Also, the patient was further scheduled for IVC filter because we couldn't do anything else for her. So my questions to Dr. Yasmin here. Is the use of the tranexamic locally offers a therapeutic benefit from the pharmacological point of view? Is it actually working locally or it's absorbed systemically and acting systemically? Okay? So, I know and Dr. Yasmin will take us through a lot of studies that was done on the topical tranexamic acid in several modalities, in several post-operative management, okay? But the use of it was concised due to the epistaxis and some prophylactic use in the post-operative, to stop post-operative bleeding. So can it stop heavy bleeding as a measure of treatment, not prophylaxis? And what about the adverse effects?
Thank you so much, Dr. Zina. Thank you, my dear professors, for allowing me to stand in front of you here today. First of all, before judging the pharmacological efficacy of using topical tranexamic acid in case of upper GI bleeding, let's first shed some light about the mechanism of action of this drug. Tranexamic acid was introduced for menorrhagia in the 1960s and is used since then for reduction of bleeding post-surgical. This drug is a lysine amino acid analog. It decreases the conversion of plasmine into plasma and so decreases its activation, decrease in reduction of fibrinolysis, preventing the breakdown of the blood clot and leading to further hemostasis. Intravenous tranexamic acid reduces bleeding in surgery. However, this drug carries uncertain risk of thromboembolic events. And so, due to a probable less systemic absorption following topical administration, it has been postulated to have therapeutic use topically with minimal risk of thrombotic events. So, Let's review the state of current evidence that supports the use of local tranexamic acid in such conditions. The presumed concerns that thrombotic events have stimulated increased interest in the topical use. Actually, studies like dental surgeries and hip arthroplasty and ulcerative colitis suggest that after topical administration, the plasma concentration of tranexamic acid reaches only less than 1/10 of its concentration after systemic use. Plasma concentration after topical tranexamic acid did not reach therapeutic levels in these studies that are considered reliable to impair systemic fibrinolysis. And so here tranexamic acid is postulated to act only locally and not systemic or through systemic absorption. In 2013, a review about the topical application of tranexamic acid for reduction of bleeding was published in the Cochrane database of systematic reviews. This review included 29 trials, among which 28 trials investigated the effect of tranexamic acid locally to reduce surgical bleeding and only one trial for the control of bleeding in epistaxis. And among the 28 surgical bleeding trials, there were trials for intra-articular tranexamic acid in hip or knee arthroplasty and cardiac surgeries, thoracic surgeries, dental surgeries, endoscopic surgeries, and post-adenoidectomy. This review concluded that local tranexamic acid provides reliable evidence to reduce bleeding and blood transfusion. However, the effect upon the risk of thromboembolic events is still uncertain due to lack of reports in some trials. Besides, the effect of topical tranexamic acid in non-surgical causes, like the case report that we have today, is still not reliably assessed. So the problem here is we have a risk versus benefit. Yes, topical tranexamic acid offers a benefit to reduce bleeding. However, there is a risk that it might increase the thromboembolic events. The CRASH-2 trial, which is a clinical randomization of antifibrinolytic in significant hemorrhage, this was a randomized multi-center placebo-controlled trial for the systemic administration of tranexamic acid that enrolled more than 20,000 patients. The results of this trial concluded that tranexamic acid decreased death and all-cause mortality without increasing the risk of vascular occlusive events. However, the problems with all the trials using either local or systemic tranexamic acid is that كل الترايلز دي ما كانتش بتستخدم او بتنرول patients عندهم already risk او عندهم history للثرومبوembolic events. الانكلوجن criteria لكل الترايلز دي كانت بتexclude البيشنتس اللي عندهم thromboembolic events. That's why the results of the Atticus trial that was published in 2017 was crucial, because specifically patients with increased risk of thrombotic events were enrolled in this trial. Tranexamic acid in the Atticus trial was associated with a lower risk of bleeding than placebo without an increased risk of higher risk of death or thrombotic complications within 30 days after surgery. Albeit, tranexamic acid here was associated with seizures that was dose-related. So, what about the use of tranexamic acid in the case we have today, which is the upper gastrointestinal bleeding? Gastrointestinal bleeding related to portal hypertension is of course a serious complication of liver cirrhosis. This bleeding is very challenging to control as there is an altered state or impaired state of hemostasis in patients with end-stage liver disease or liver cirrhosis. A previous study published by the anesthesia staff here in Ain Shams University showed that the addition of tranexamic acid to the nasogastric lavage in patients with hematemesis significantly improved blood loss and decreased the transfusion requirements and decreased the time for upper endoscopy. In 2014, again, the Cochrane Database of Systematic Reviews published a review about the use of tranexamic acid in upper gastrointestinal bleeding. However, here tranexamic acid was used systemically, not topically. 8 RCTs, randomized controlled trials, were enrolled in this review, and the conclusion of this review was that yes, tranexamic acid has a beneficial effect on mortality. However, recommendations cannot be made based on this review due to the high dropout rate in these trials. And so we still have this controversy whether or not to use tranexamic acid topically along with other modalities to control bleeding in gastrointestinal bleeding due to the lack of insufficient data or evidence about this. We still need a well-planned, large randomized control trials with adequate sample size and proper concealment with well-defined outcomes like the amount of blood loss and the need for blood transfusion and the thrombotic events and seizures. And we still need trials also to compare the plasma levels of topical tranexamic acid versus systemic tranexamic acid before anyone could recommend the use of tranexamic acid in gastrointestinal bleeding. Thank you.
شكرا. هنخلي الدسكشن في الاخر بس هو الموضوع ده انترستنج جدا. احنا كنا السنه اللي فاتت بنناقش الانتراسيكل انجكشن والكومبليكيشن اللي بتحصل منه. وللاسف لحد يمكن الاسبوع اللي فات برضه بتيجي حالات ان بيعملوا سايكلوكابرون مكان المكين. اللوكال ترانكزاميك اسيد بقاله مثلا حوالي 3-4 سنين بقى وايد يوزد. يعني كل حالات الارثرو بلس دلوقتي بيستخدموا لها السايكلوكابرون. الظريف فعلا واللي جربته شخصيا مع زمايلنا اساتذه اليورو او يورو سيرجري في الحالات البروستيتس تي ار بي بيبقى فيري افيشنت لدرجه دلوقتي ان اي لوكال اوز يبداوا يحطوا ترانكزاميك اسيد لوكال. فكان الفكره هل فعلا بيفيد ولا لا؟ بعد كلام الدكتوره ياسمين الريسك فيرسس بنفيت. I think ان البنفيت more than the risk in this condition. كان في حد من الزملاء زمايلنا يعني مسجل MD كان ليا شرف المناقشه بتاعتها من حوالي برضه يمكن 3 سنين على اللوكال يوز اوف سايكلوكابرون في حالات السوراكوتومي. وطلع ريزلت انها فيري افكتيف. هو كان السؤال اللي احنا عايزين نوصله او الدكتوره ياسمين اعتقد انها جاوبت عليه. هل في كومبليكيشن من اللوكال زي بالظبط اللي بيستخدموا انترافينوس؟
هو حتى بتاع الانترافينوس بقى يعني الاي اللي هو الاي في الترايلز كلها اللي اتعملت على الكوشرال داتابيز لقيت ان اونلي وان كيس جالها بالمونري امبوليزم من الاي في يوز اوف ترانكزاميك اسيد من كل الترايلز اللي اتعملت وتقريبا 0.03% اونلي من برضه الاي في يوز. فاذا كان التوبيكال احنا بنتكلم على كونسنتريشن ماتش ليس.
هي الدكتوره ياسمين قالت about 1 tenth. I think ان هي ان لحد الكلام اللي احنا سمعناه من حضراتكم ان البنفيت مور ذان ذا ريسك ان ذيس كونديشن.
بس
مفيش كونترا انديكيشن.
لا كونترا انديكيشنز
الا نستخدم التراسيكل. شكرا.
To welcome Dr. Rania Hassan, a lecturer in athletics in Ain Shams University, and Dr. Dina Osama, a clinical pharmacist, to speak to us about the post-operative anticoagulation and re-administration of post-operative dilemma to be solved.
It's an honor to stand here today to discuss a dilemma that meets every anesthesiologist
In patients having or on anticoagulation, there is a dilemma whether to stop the anticoagulant before surgery or not. This puts either the risk of bleeding or either the risk of the thrombosis when we stop the anticoagulation. Today we have a case, a 73 years old male with history of episodes of chronic stable angina. He had right coronary drug-eluting stent inserted 2 weeks ago. He's on aspirin and clopidogrel. He had fractured neck femur and needs bipolar hemiarthroplasty. Our questions today: does he need to stop the antiplatelet agents prior to surgery? How soon prior to the procedure we will stop, we retain them? How soon it can be restarted after surgery? Dr. Tina will discuss this issue.
The management of anticoagulation in patients undergoing surgical procedures is challenging to balance between the risk of thrombosis and the risk of bleeding. So we have an approach for decision making, whether to stop anticoagulation or to continue them or to use bridging or whatever. So we have to estimate first the thromboembolic risk, then estimate the bleeding risk, and determine the timing of anticoagulation interruption if we made the decision to stop them, and determine whether to use bridging anticoagulation or not, especially with patients taking warfarin. First, estimating the thromboembolic risk. The most important risk factors that increase thromboembolic risk are atrial fibrillation, prosthetic heart valves, and recent thromboembolism or atrial thromboembolism within the recent 12 months. So we made this classification for the high thrombotic risk or very high or moderate. The very high thrombotic risk are in mechanical ventilation, any mitral valve prosthesis within 6 months, AF CHA2DS2-VASc score more than 6, and recent VTE within 3 months. The high thrombotic risk is any aortic valve prosthesis and other risk factors like AF and stroke or TIA hypertension, CHA2DS2-VASc 3 or 4 or 5, and recent VTE in the past 12 months. And the moderate thrombotic risk, any bileaflet risk valve without any risk factors, CHA2DS2-VASc 2 to 3, and VTE more than 1 year. Estimating the bleeding risk. Higher bleeding risk confers a greater need for perioperative hemostasis and thus longer anticoagulation interruption, according to the risk of bleeding in surgery. So they were classified according to high bleeding risk surgeries and low bleeding risk surgeries. High bleeding risk surgeries, like our patient in this case, is hip replacement surgeries, knee biopsy and others, and low bleeding risk like tooth extraction or non-coronary angiography. So the oral anticoagulations and antiplatelet agents that should be stopped in our case, like aspirin, in most cases we do not stop aspirin as it does not increase the risk of bleeding, and in very high risk we can stop them 5 to 7 days before surgery. While clopidogrel has a high risk of bleeding, therefore we have to stop clopidogrel 5 to 7 days prior to surgery in high risk bleeding surgeries. دي screen shot من الجايدلاينز تقول ان low dose aspirin does not increase the clinically important bleeding risk in patients in surgeries، بس الكلوبيدوجرال does، عشان كده بنوقفه 5 أو 7 أيام قبل العملية. Dual antiplatelet therapy as this patient he was on that عشان هو عامل لسه ستنت بقاله أسبوعين، ده بيزود الريسك of thrombosis للستنت، علشان كده العيان ده كان هاي ريسك ان هو يحصل له ثرومبوزس، فعشان كده احنا استعملنا له دابت اللي هي dual antiplatelet aspirin using clopidogrel. الجايد لاينز بتقول ان الدابت range من 4 weeks in patients undergoing elective stenting في bare metal and 12 months لازم يبقى ماشي على دابت لو هو عامل drug eluting stent. The current guidelines recommend elective non-cardiac surgeries to be postponed 6 weeks following angioplasty with bare metal stent and 12 months بعد the drug-eluting stents. Perioperative continuation of aspirin slightly increases the bleeding risk, but does not increase the bleeding that requires any medical or other interventions for the patient. عشان كده احنا عادي ممكن نكمل aspirin during the surgery. If a patient has to undergo surgery with a high bleeding risk and antiplatelet effect is not desired, clopidogrel should be discontinued 5 to 7 days prior to the procedure.
The first question was that this patient need to stop antiplatelets period to surgery. According to the stratification that Dr. Dina discussed, we can put this patient at first to continue. We have to perform a multidisciplinary team, the cardiologist and the anesthesiologist and the surgeon to discuss which is better to the patient. This patient, we can put him for the high thrombotic, we will classify this patient as a high thrombotic patient, and he is for high hemorrhagic risk. So in these cases, according to guidelines, we have to complete with aspirin, stop clopidogrel 5 days, and then return it. When to return this treatment after 24 hours after stabilization of the condition. The third question. We will stop it 5 days. Some authors prefer to, the arising new lines are the IV short-acting antiplatelets, which is rising since 218, but still not present. Thank you.
طب هو برضه ممكن سؤال بعد ذلك، هو احنا التراديشنال دراج اليوتنج ستنت اتس بيتر تو بوستبون سيرجري او اوكي؟ طيب لما بتيجي حاله ان العيان مركب دراج اليوتنج ستنت فور 4 ويكس والعمليه او هو عايز يعمل عمليه او سكند ستيج من نون كاردياك اوبريشن. والله بص الحاله دي احنا واجهناها وبعدين النيو جايد لاينز بتقول اكوردنج للحضرتك قلتيه انه يبقى في ديسكشن بين التيم كله بس اتس بيتر تو بوستبون العمليه اب تو 3 مانثس. كانت 12 شهر دي بقت
في حتى بيبرز كاتبه ان احنا في حاجه زي الفراكشر ده لو ينفع يمشي كونزرفتيف لو مش هيأثر على اللايف بتاعت البيشنتس نختار الليست انفيزيف بروسيجر اند بوستبون سيرجري. هنا السيرجري دي بتتقسم حسب انها سيمي ايرجنت، يعني ممكن نستنى وقت من 5 ايام اللي هم هنستوب فيهم الكلوبيدوجرال، او لو نقدر ندسكس مع الجراح والعيان يمشي كونزرفتيف مثلا زي ما بيعملوا شده او حاجه، وحتى لو هيسيب اليمنت اوف ان العيان يبقى عنده مشكله بعد كده هيبقى مور سيف للعيان، لان الانسيدنس اوف مايوكارديال انفاركشن افتر ستوبج اوف ذا دات از فيري هاي.
تمام، بس انا اللي بقصده هل تبوستبون الاوبريشن زي ما كنا بنقول دلوقتي 12 شهر ولا
لا الكيس ريسيت جايد لاينز 3 months.
Thank you أولا دكتور رانيا ودكتور دينا for the presentation. Actually nowadays there is a conflict between our guidelines and the orthopedic guidelines. Orthopedic guidelines, Dr. as you know, they are insisting to do the operation, especially in the fracture within at هو المشكله ان احنا دايما الجايد لاينز بتاعتنا بتبقى داخله في سكه الريجنال انستيزيا وات ايفر نيورو اكسل او بريفرال نيرف بلوك. هم يعني برضه الجايد لاينز دي should be discussed رانيا deeply with the surgeon because يعني they are insisting to do the operation within 48 hours. These are the recent guidelines for the orthopedic so as to improve their results or outcome of the patient.
That he can go with Plavix without stop.
Without stop. مش ما
لا without regional anesthesia for general anesthesia.
السؤال الاهم يا دكتور هو بوستبون اوبريشن 12 شهر ولا 3 مانثس؟ دلوقتي لو ممكن 3 مانثس بس في possibility يبقى في كرونيك ستروك بتبقى عاليه شويه. بس اكسب.
هو بالظبط كده، بس هو يعني برضه ما بنناقش المشكله بتاعت العيان ده لو بيد ريدن 3 مانثز او يعني
تمام. الريسك هيبقى اعلى لو ما عملش العمليه.
عايز اشكر الجماعه بتوع الفارماكولوجي بتوع عين شمس بصراحه، يعني اجيال مشيره، وهي الدكتور احمد بتوع احنا عارفين بس جديد بتوع كلينيكال
Third presentation, antibiotic administration and the precision of dose. Dr. Rania Magdi, Assistant Professor of Anesthesia and Intensive Care at Shams University.
Assalamu alaikum. I'm Dr. Rania Magdi, Assistant Professor of Anesthesia and Intensive Care at Ain Shams University. It's a great pleasure to be with you today. I used to speak in the session of the clinical pharmacology every year under the guidance and the supervision of Dr. Baha and Dr. Muhammad Nuruddin. It was planned that he will speak with me today about this hot topic, but unfortunately he couldn't make it. The provisional title of the topic was about dosing of antibiotics in the critically ill patients. It was a very, very wide topic, and there is a lot to be told about it nowadays. So we concise it to speak about the MDR and the multi-resistant bacteria in critically ill patients. We had this interesting case about a 60-year-old man whose body weight was 100 kilogram and body mass index 35 and was admitted to the ICU after septic shock following gastric perforation. Procalcitonin level and CRP were elevated, and culture from the drainage fluid showed Klebsiella easpial, which was sensitive only to meropenem or meropenem and imipenem, and Acetobacter, which was only sensitive to cholesterol. A blood culture was withdrawn on day 4, and its result was negative. After treatment with meropenem, 1 gram every 8 hours and colistin for 7 days, the patient clinically improved. So antibiotic was discontinued. And here started the problem. And the dilemma that 4 days later, the patient clinically and hemodynamic condition worsened and become feverish. Both the total leukocytic count and the CRP were elevated again. As the culture was negative, treatment was changed to imipenem high dose, 1 gram every 6 hour extended infusion over 3 hours, and colistin high dose with a loading of 9 million and maintenance of 4 to 5 million every 12 hours. Fortunately, the patient's clinical status improved. Vasopressor was stopped and the inflammatory parameters decreased. He was treated for 12 days and finally returned home at day 48 with no further antimicrobial treatment. The question now, we resumed the antibiotics without culture and without knowing which antibiotic would be sensitive in this case, and we faced a lot of challenges. Like, what is antibiotic resistance truly a serious health care threat? Should we stop antibiotics if symptoms resolve as we did in this case? Or whether it was a risk for such a patient and was a cause for his infection with a more extended spectrum of multi-drug resistance, and how to monitor the response of antibiotics to ensure that patients are treated adequately and infection relapses are prevented. We all know that ICU patients are particularly likely to develop infection for many reasons, like infection maybe the cause of a patient admission to the ICU. Usually patients in the ICU are immunocompromised, and also we insert a large number of devices in such patients which may increase the risk of infection. Choosing the correct and adequate antibiotic coverage is essential, but can be complex because of delayed identification of the microorganism, as the traditional blood culture usually takes not less than 4 days, and if and that's in the very good conditions. Sometimes when we face the weekend days, it might be extended to 6 days. The impact of critical illness on the therapy may affect the pharmacodynamics and the pharmacodynamics of the antibiotic. Also, there is high prevalence of antibiotic-resistant strains arising nowadays. The multi-drug resistant organisms account for 80% of infectious episodes in the ICU. And we used to call them SCAPE with K. Later on, it was changed to SCAPE with E. By adding the Clostridium difficile, by adding the Clostridium difficile and widening the range from Enterobacter to Enterobacteriaceae to add the E. coli and the Proteus. Because of the increasing level of antibiotic resistance, including extended spectrum beta-lactamase, carbaminomases, and the aminoglycoside resistance, with decreasing level of chloroquine susceptibility among these organisms. We need to know how to diagnose and to reach good and early detection of the microbial infection in the ICU. We first depend on the clinical signs such as a fever, raised white blood cell count, which is non-specific. We can also use the biomarkers like inflammatory biomarkers like CRP and procalcitonin. Both of them are non-specific, yet procalcitonin titer can be more specific. Using the culture-based technique, it takes several days for a positive result to be available. And in patients already receiving antibiotics, cultures may be negative, as what happened in our scenario, that when we measured the clinic, we took a culture on the fourth day to detect whether to stop the antibiotic or not after improvement of the patient's clinical condition. It was a negative culture, and it deceived us and directed us to stop the antibiotic. PCR and mass spectrometry with or without electrospray ionization are more rapid microbiological identification method, yet it is not available in all our labs, and it's a little bit much more expensive. Antibiotic stewardship and infection control studies aims to provide assistance with optimal choice of the antibiotic, choosing the dosage, the pharmacodynamic and pharmacocharacteristics of the antibiotic, and its duration. All this to help to decrease the cost, adverse events, and the development of resistance. This slide will show us how the evidence-based guidelines of the Surviving Sepsis campaign in 2018 adopted new bundle for the patient with sepsis or septic shock sustained by MDR infections, as to assess the possible immune dysfunction. The lymphocytic count, the HLA-DR expression on the monocyte and viral reactivations are nutrients that we need to establish in the first hour of septic shock. Also, obtain surveillance culture as soon as possible and use rapid method for identification, not depending on the traditional method and using PCR and rapid phenotyping. In addition to administration of combination of broad spectrum of antibiotics. Lastly, using adjuvant therapy in the form of immunomodulatory treatments, mainly immunoglobulins, that is the most things that we can use nowadays. We can use propylstolin to reduce the exposure to antibiotics in our ICU. In 2010, the PRO-RETA trial was done. Also in 2008, another trial was done. Both of them revealed that biomarkers such as CRP and procalcitonin can be used, and that procalcitonin is more specific to bacterial infection. The use of procalcitonin guided algorithm has been shown to reduce the duration of exposure up to 25%, which will decrease the cause and the extension of the MDR infection. Here is the algorithm. If we suspected sepsis in critically ill patient, we obtain a baseline procalcitonin level and repeated daily. When it dropped below 0.5 picogram per liter or more than 80% from the peak patient clinic from the peak level, this will indicate patient improvement, and that's the point that we will stop the antibiotics at. I want to highlight that if procalcitonin level do not decline despite therapy, we consider it treatment failure, and we have to shift to another type of antibiotic. And that's the procalcitonin algorithm applied to patients with clinically confirmed infection as well, those who do not have obvious or clear infection. Also, procalcitonin algorithm can be used as a clinical decision aid, but we should never override clinical judgment. There is other methods to diagnose multi-drug resistance. One key aspect, one of them is the immunocapture coupled PCR, or the multi-dilution method used to detect carbamidase-producing organisms. It may, there is a more advanced method which is called the chromogenic agar, which has less than 16 hours, which helps in the detection of the antibiotic, of the organism. MDR. This is a horrifying terminology used nowadays, because the spreading antibiotic resistance is not matched by development of equally effective antibiotics. This demand for effective utilization of all antibiotics that are possibly active against multi-drugs and extremely drug-resistant bacteria. The question now, would I ask you, do you know how to, when to say that is an MDR, XDR, or PDR, or what is the difference between them? Okay, now this is the mechanism of resistance of classes of antibodies used to treat the commonly resistant pathogens. As we see, it can be, moves from a change in permeability in the aromatic destruction, altered binding site, or the efflux of the antibiotic used. The International Health Organizations named the European Center for Disease Prevention and Control and the Center for Disease Control and Prevention. Both of them use terms to highlight the rapid emergence and spread of such antibiotic resistance, like crisis, catastrophic consequences, and nightmare scenario. When to call it MDR? We call it MDR when there is non-susceptible to at least one agent in 3 antimicrobial categories. Whereas XDR when non-susceptible to at least one agent in all but 2 or fewer antimicrobial categories. And pan drug resistance when non-susceptible to all agents in all antimicrobial categories. That's why we consider multi-drug resistant MDR as a subgroup from the XDR, and the XDR is a subgroup from the PDR. As we can see, this is the antimicrobial categories used to define MDR, XDR, PDR. And we need to check the result of the antimicrobial susceptibility testing to know whether it is MDR or not. That's used for the Enterococcus, and that is its continuation. Okay, and that's for Pseudomonas, and that's for Acinetobacter. And this is a solved one. We can, as we can see, in the isolate number 1, there is non-susceptibility to most of the antibiotics, whereas in the XDR there are at least 2 groups which are susceptible to, and the MDR when there is more than 2 unsusceptible groups. Colomycin injection or colistin is one of the most used drugs of antibiotics in such cases. We reserved intravenous colistin for infections due to polymyxin susceptible multi-strain bacteria and preferably used in combination with other agents. We can give careful consideration to use higher dosage regimen in critically ill patients. And that's what happened in our case scenario when we used a higher dose after reinfection or deterioration of the condition of the patient. It's usually used to treat KFC-producing Klebsiella. If the Merinam MIC minimum inhibitory concentration is less than 8, we use colistin with Merinam. If the Merinam is between 8 to 32, we use higher Merinam dose by continuous infusion. Whereas when the minimum inhibitory concentration is more than 32 mg per liter, we consider colistin with aminoglycoside tigecyclines in infections with strains producing KFC or other carbaminases which are susceptible to this antibiotics. The point I want to stress about here that most of blood cultures we receive in our units do not mention the MIC. They tell us that this antibiotic is sensitive or resistant for this microorganism or this. So we need to identify, typically it is, should be a formal request and we insist on it to have the minimum inhibitory concentration. As knowing the minimum inhibitory concentration will lead us to different doses of antibiotics to be used. While using colistin, we need to monitor the renal function, especially in elderly patients, those who receive it for prolonged periods and those who receive it with concomitant nephrotoxic agents like aminoglycosides. The standard dose is 2 milliunits per 8 hours. Evidence is emerging that higher doses regimen may be more appropriate in the ICU setting with therapeutic drug monitoring to target a peak concentration of 5 to 15 mg per liter and a trough of 2 to 6 mg per liter. And that's raised another question, whether measuring the drug concentration, the antibiotic concentration in the blood, should it be a new method of guiding the administration of antibiotics in critically ill patients with altered pharmacokinetics and pharmacokinetics characteristics? This paper done in 2012 indicated that high doses of external interval colistin administration in critically ill patients in life life-threatening infections caused by gram-negative bacteria susceptible only to colistin. We used a loading dose of 9, they used a higher dose of 9 million units followed by 4.5 million units per 20 hours. That was reduced with renal impairment and resulted in reversible mild renal injury in only 5 patients. That was reversed within 10 days from rising the creatinine level. Moving to the Tynam and the Meronym, imipenem and Meronym using to treat serious infections with ESBL and AMPCA producing Enterobacteriaceae. Apply antibiotic stewardship to use all carbaminians to minimize the risk of developing resistance either by acquisition of carbaminase producing strains or with interpenem by purine loss. We do not use imipenem to treat the Salter pseudomonas infection. Test all Meronym and imipenem resistant isolates of Enterobacteriaceae immediately for the precise level of resistance and whether is it MDR, XDR, PDR for an indication of the responsible class of carbaminase. Submit to agreed reference laboratories to determine susceptibility to a wide range of potentially active agents, including, as appropriate, colistin, ceftriaxone, timosalin, aminoglycoside, and others. Consider use of continuous infusion of Meronym in combination at dose determined by nomogram if infection with KFC carbaminase producing Klebsiella with minimum inhibitory concentration of more than 8 or less than 64 milligram per liter. We know that both of them are time-dependent antibiotics, and they exhibit maximum bactericidal activity when unbound concentration of the drug exceeds the minimum inhibitory concentration. Beta-lactam antibiotics demonstrate a time-dependent effect on bactericidal infection. Prompt infusion strategy may improve bacteriological and clinical cure, especially when pathogens demonstrate high minimum inhibitory concentration. Continuous infusion over the entire dosing interval or at extended infusion over 2 to 4 hours. Thank you.
كان سؤال يا دكتور رانيا عن الكوليسترول دوز. انت قلتي
الكلاسيك 2 مليون يونت، لكن ممكن نزوده ل 4.5 ل 9 كالوديك و 4.5 كمينتنس مليون يونت.
انا عايز اقول لك ان هو كمان ممكن نوصل، انا في بعض الحالات وصلنا ل 12 ووصلنا ل 16. يعني هتلاقي في 2 أو 3 ستاديز منشورين عن الهاي دوزز very high doses of cholesterol actually was very effective يعني.
هو احنا في الكيس اللي احنا اتكلمنا عليها دلوقتي كانت احنا حتى لما عملنا
الدوز اللي انتوا استخدمتوها كانت كام؟
احنا الاول استخدمنا الكلاسيك دوز اللي هي ال 4.5 وبعد كده طلعنا ل 9. يعني احنا في الاول لما لقينا احنا لما جينا في المره الثانيه ما كناش طالع لنا في الكالتشر، ما كناش عارفين ان كانت هي ام جي ار ولا اس دي ار ولا بي دي ار، ان هي كانت طالعه لنا الكالتشر نوجراس. فاحنا استخدمناه امبيريكال ويز ذا هاي دوز عشان يعني يعني هو ده اللي بيبقى السلاح الفاضل للعيان. لو احنا ما قدرناش ان احنا نزود الدوز مش هيبقى ورانا ما عندنا حاجه ثانيه نقدر نديها له.
كنت استخدمتيه ان كومباينيشن ويز ميرون.
ويز ميرون يس.
هو طبعا في شغل كتير برضه على بيقارنوا الكوليستين الون او الكوليستين ميرون.
الكومباينيشن ويز ميرون او الكومباينيشن ثيرابي بيقولوا ان هو از بيتر لما كل ما زادت الريزيستنس بتاعت الانتي ميكروبيال اللي عندي.
ثانك يو دكتور.
آخر محاضرة دكتورة نورة يوسفي، دكتورة آية، نيو treatment site for antibiotic preoperative administration in rheumatic heart disease patients.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Noura Yusri, lecturer of anesthesia, intensive care and pain management at Ain Shams University. I'm proud to share in the 37th International Annual Conference Egyptian Anesthesia. And I'm proud to have Dr. Aya Sha'arawi Abdushafi, head of the clinical pharmacy department at the Obstetric and Gynecological Hospital. Our topic today is new insights for antibiotic preoperative administration in rheumatic heart disease patients. This is a patient, 28 years old female patient scheduled for tooth extraction. Patient suffered from rheumatic mitral stenosis. 1 hour prior to the procedure, patient received amoxicillin as a prophylaxis against infective endocarditis. Patient developed allergic reaction that was managed and the procedure was postponed. What the antibiotic prophylaxis for infective endocarditis indicated here, and what is the recommended regimen?
Infective endocarditis is a deadly disease associated with high mortality and severe complications. So the principle of antibiotic prophylaxis for infective endocarditis was developed based on observational studies and animal models, and in preventing attachment of bacteria into the endocardium after transient following invasive procedure. This concept previously led to recommendation for antibiotic prophylaxis in large number of patients with predisposing cardiac conditions undergoing wide range of procedures. I'm going to discuss the history of antibiotic prophylaxis. First, in 1955, the use of antibiotic prophylaxis was first suggested by the American Heart Association, the first guideline that recommends the use of antibiotic prophylaxis in the form of parenteral combination of penicillins and streptomycins. In 1982, the British Society for Antimicrobial Chemotherapy produced the first UK guidelines, which was moving towards the use of oral dose, a single oral dose, not combination therapy, for antibiotic prophylaxis. Then after that, in 2007, the move to restrict the number of individuals who should receive antibiotic prophylaxis. Not all patients at risk of infective endocarditis, only the highest risk patient for infective endocarditis and its complication. In March 2008, the NICE guidelines recommend the complete cessation of antibiotic prophylaxis for all procedures and all patients to prevent infective endocarditis, which was based on economical studies that conclude that there is uncertainties about the risk of infective endocarditis, and the use of antibiotic prophylaxis was costly ineffective. But in September 2015, the American Heart Association and the European Society of Cardiology announced their updated guidelines evaluating the same evidence and recommend the restriction of antibiotic to high-risk patients only, undergoing a risk procedure. Which was the reason for antibiotic restriction for high-risk patients. The reason behind this decision that the cumulative low-grade bacteremia during daily life, rather than the sporadic high-grade bacteremia after dental procedure, cumulative low-grade is more risky account for high bacteria and the attachment of bacteria to endothelium, rather than after procedure. So the estimation of the risk of infective endocarditis following the dental procedure is very low. And the widespread use of antibiotics may result in the emergence of resistant microorganisms, our issue in the last with Dr. Rania. And the risk of anaphylaxis and skin-related drug eruptions from antibiotic is very low, but become more significant with widespread use of antibiotics. And the efficacy of antibiotic prophylaxis on the occurrence of anti-infective endocarditis proven only in animal models, but controversial in human models. My question here, why we restrict antibiotic prophylaxis and not complete seated use of it according to the NICE, a complete station of use of antibiotic prophylaxis. The European Society of Cardiology guideline 2015 for the management of infective endocarditis maintains the principle of antibiotic prophylaxis in high-risk patients for the following reason. The worst prognosis of infective endocarditis in high-risk patients, particularly patients with parasitic valve. The fact that high-risk patients account for a much smaller number than the patients at intermediate risk, so reducing potential harm due to adverse event of antibiotic prophylaxis. And last, the remaining uncertainties regarding the estimation of the risk of infective endocarditis. So my question here to Dr. Noura, which patient at least of developing infective endocarditis that require antibiotic prophylaxis?
The patient with highest risk of infective endocarditis, according to the 2015 European Society of Cardiology guidelines and the 2017 American Heart Association guideline, they were categorized into 3 categories. Patient with prosthetic valve or prosthetic material used for cardiac valve repair, or patient with transcatheter implanted prosthesis or homograft. These patients, they have higher risk of developing infective endocarditis, and also they have higher mortality and morbidity. They may develop severe complications from infective endocarditis. Patients with previous infective endocarditis also have higher risk to acquire another episode of infective endocarditis, and this time the morbidity will be higher and they may develop more severe complications. The patient with untreated cyanotic congenital heart disease and those with congenital heart disease who have post-operative palliative shunts, conduit, or other procedures. After surgical repair with no residual effect, the task force of the European Society of Cardiology task force recommended prophylaxis for at least 6 months after the procedures until the reindustrialization of the prosthetic material. Actually, the American Heart Association and the American College of Cardiology also added the cardiac transplant recipients with the cardiac valvulopathy to the highest risk of to the patient with high risk of infective endocarditis, but this is not supported by strong evidence. So the European Society of Cardiology did not recommend antibiotic prophylaxis for those patients. Antibiotic prophylaxis is not recommended for intermediate risk patients, such as the patient with native valve disease, and the most common mitral valve replacement, bicuspid aortic valve and the calcified aortic stenosis. Those patients are not recommended to have antibiotic prophylaxis before any procedure. What is the recommended regimen for antibiotic prophylaxis, Dr. Aya?
The recommended regimen was based on the most suspected microorganism mounted in the oral cavity and on the skin. So a patient should receive oral antibiotics. If not able to take oral medication, he will receive IV antibiotics like ampicillin or cefazolin or ceftriaxone. لو البيشنت كان عنده penicillin allergy أو في allergy من ampicillin will receive clindamycin or azithromycin or لو can't take oral medication will receive IV clindamycin with doses here. For patient, this is a special situation for patient on long-term penicillin or any previous antibiotic for any other reason. يعني if the patient take amoxicillin or ampicillin أو cefazolin أو ceftriaxone for any other cause of any other reason, should be shifted to clindamycin or azithromycin. Or if delayed until at least 10 days after completion of antibiotic to allow re-establishment of usual non-oral flora. Or I can use ampicillin, and I can use, after that I can use ampicillin or cefazoline or ceftriaxone. This note I will discuss the timing of administration of antibiotic according to the American Heart Association guidelines state that antibiotic for prophylaxis should be administered in a single dose 30 to 60 minutes before the procedure, and if not by mistake not administered before the procedure, I can give 2 hours after the procedure. And in this situation, where patients are receiving long-term parenteral antibiotic for treatment of infected endocarditis, infected emergent operation, emergent surgery, the procedure should be timed to cure also 60 to 30 to 60 minutes after delivery of parenteral antibiotic. This high dose of antibiotic will guarantee high concentration, which will overcome any possible low-level resistance in normal flora.
5 years later, the same patient was readmitted to obstetric and gynecological ER with 38 weeks pregnant in labor for normal vaginal delivery. She gave history of mitral valve replacement 2 years before. So the question is now, is antibiotic prophylaxis for infective endocarditis is indicated now, Dr. Aya?
This patient, high risk patient with the mitral disease, high risk patient, but not undergoing high risk procedure. Our approach in a high risk patient should receive antibiotic if undergoing high risk operation. So I'm going to ask Dr. Noura, what is the high risk procedure that need antibiotic prophylaxis?
Regarding the high-risk procedure or procedures at risk of developing infective endocarditis, this summarizes all about it. There is dental procedures, only the dental procedures that require manipulation of the vagina or periapical lesion of the tooth or perforation of the oral mucosa are requiring antibiotic prophylaxis before the procedure. Local anesthetic injection in non-infected tissue does not recommend any antibiotic prophylaxis. Regarding the other procedures, respiratory tract procedures such as bronchoscopy, laryngoscopy, transnasal or endotracheal intubation, there is no indication for antibiotic prophylaxis unless there is an established infection. This time the antibiotic regimen should contain anti-staph drug. Regarding the gastrointestinal urogenital procedures or the transesophageal echo, gastrointestinal procedures such as gastroscopy or colonoscopy and the urogenital such as vaginal delivery or even cesarean delivery, these are not high-risk procedures. It's not recommended to give antibiotic prophylaxis before the procedure unless there is established infection or the antibiotic is prescribed to prevent wound sepsis and infection. Here it's reasonable that the antibiotic regimen include an agent active against enterococci such as ampicillin, amoxicillin, or vancomycin in patients who is unable to tolerate beta-lactams. Regarding the skin and soft tissue procedure, there is it's not recommended to give antibiotic prophylaxis in even the high-risk patients. Regarding cardiac and vascular intervention, patient undergoing implantation of a prosthetic valve of any type or prosthetic graft or pacemaker, preoperative antibiotic prophylaxis are required because there is high risk of developing infective endocarditis and there is a worse outcome of the infective endocarditis easy to have it. The most frequent microorganism underlying the prosthetic valve infection are the coagulase negative Staphylococcus and the Staphylococcus aureus. Prophylaxis should start immediately before the procedure and be repeated if the procedure is prolonged and terminated 48 hours after the procedure. You can also do preoperative screening for the nasal carriage of Staph aureus. It's recommended for elective cardiac surgery and treat the nasal carriers we using local mupiracine and chlorhexidine. Systematic treatment of local treatment for patient before elective cardiac surgery is not recommended unless there is a preoperative screening first.
It's strongly recommended that potential sources of dental sepsis should be eliminated 2 weeks before any elective cardiac surgery or any implantation of any prosthetic valve, unless, of course, the procedure is urgent. Healthcare associated infective endocarditis, it represents about 30% of the infective endocarditis cases, and they are characterized by increasing incidence and severe prognosis. Simply by applying aseptic measures during insertion and manipulation of a venous catheter during any invasive procedures, it are mandatory to reduce the rate of healthcare associated infective endocarditis. To summarize, the 2015 European Society of Cardiology guidelines and the 2017 American Heart Association guidelines recommended to continue limiting antibiotic prophylaxis to only high-risk patients and to undergoing only high-risk procedures. Regarding the invasive respiratory tract, gastrointestinal, urogenital procedures, antibiotic prophylaxis is not recommended unless there is established infection or if antibiotic therapy is indicated to prevent wound infection or infection or sepsis. Non-specific infection control measures are of great importance to decrease the incidence of healthcare-associated infective endocarditis. And finally, although guidelines of infective endocarditis prophylaxis is based on weak evidence, they have been strengthened recently by epidemiological surveys. Thank you.
Very good. واحنا نستأذنكم هناخدها نعملها زي جايد لاينز كده في موقع الجمعيه، لان بعد المحاضره دهيت اعتقد ان استخدام الانتي بيوتيك في اي عين يقول لك عنده روماتيك فيفر ابيوزد، هيخلع سنانه ابيوزد، العيان مركب فالف يبقى ياخد طول عمره انتي بيوتيك. الكلام اللي سمعناه ان هي 6 مانثس اب تو 1 يير، مش كده؟
ده في العيانين السيانوتيك، العيانين كونجنتال هارت اللي عمل
كونجنتال هارت. تمام. احنا دلوقتي بنفتح المناقشه، لو حضراتكم في اي سؤال اي استفسار. شكرا جزيلا. شكرا.